Good afternoon, everyone, and welcome to Medical Grand Rounds. Before we get started, just a quick reminder to please leave your questions till the end of the presentation and please enter them in the chat. As well, we ask you to please fill out a brief survey at the end of the presentation. This will let us know that you were here today. Our grand rounds today are courtesy of the Division of Internal Medicine, and we have 4 speakers today. Very exciting. We're going to hear more about innovations in medical education, changing the landscape for our learners. Before we get started, I'd like to introduce the speakers. We have Dr. Matthew Ades, who is a PGY5 resident in GIM at McGill, currently completing a master's degree in health science education at the University of Ottawa, and his interests include medical simulation in postgraduate medical education. We also have Dr. Jonathan Houle, who is a general internist with an epidemiology master's student at McGill. His interests are point-of-care ultrasound, the epidemiology of non-communicable diseases, and global health. We have Dr. Jeffrey Wiseman, a general internist at McGill and a core member of McGill's Institute for Health Sciences Education. He's also the Director of Education at the McGill Steinberg Center for Simulation and Interactive Learning. His interests include serious games, you'll have to tell us about that, technology-rich learning environments, the role of emotions in clinical reasoning, and application of educational psychology frameworks to understand and improve everyday clinical educational practices. And finally, Dr. Linda Snell, known to many of you, is a general internist at McGill, a core member of McGill's Institute for Health Sciences Education, and a senior clinician educator at the Royal College of Physicians and Surgeons of Canada. Her interests include faculty development for competency-based education, advanced training for clinician educators, education leaders, and medical education scholars. And finally, in learning and teaching and assessing the CanMed's competencies. I will stop there and hand it over to you, Linda. Thank you, all of you, for joining us. Linda, go ahead.
Thank you very much. I am assuming, unless I hear otherwise, that you can actually see the slides. Am I correct?
Yes,
all right. So thanks. You will also notice that I have added Ningxi's name to this because we had one of our presenters was voiceless yesterday, and Ningxi may have to step in if the same thing happens today. So we thought we'd talk about something that our division does a lot of, and that's medical education or health sciences education, and also particularly innovating in education. And the goal of the rounds is really to hear about a couple of innovations in medical education, understand what an innovation is and what makes a successful innovation, and also to recognize that these are not just things that come out of the blue, that there's actually a science, an education science behind medical education innovations, and also to do a little bit of a what's in it for you, the audience, what's in it as a practical application for a clinician teacher. So it's going to be a multiple person presentation. I'm going to talk really briefly about innovations in med-ed. Then we're going to hear about one innovation on POCUS teaching from John. And then Jeff will give us a very brief overview, he'll be the muse and do a commentary on what are the education concepts and the applications for you. Then we'll have a few questions. And so if you have specific questions about this, please put them in the chat. Then we'll move on and do the same thing for a second innovation that Matt has done. And again, Jeff will be the muse and there'll be some questions and comments on that. So I'm going to start really briefly. I can get my slides to move by talking about what's an innovation. Well, an innovation in medical education is really very much like an innovation anywhere else. It's a new approach, often to solve a real problem or to address a need. It can also be, particularly in education, adapting an older approach to a new context or to new content. So the innovation is not the goal in itself. The innovation is a means to achieve an education objective. For example, to improve learning outcomes or processes with a valid measure of success, to, very importantly, improve learner or teacher or both's well-being, to improve cost effectiveness or cost efficiency, really important these days when resources are limited, and cost effectiveness, particularly in a certain context, to refine either teaching process or an assessment method. Innovations are also, when we do them, a source of professional development for us. We learn as we innovate, and innovations address a need. So let's consider the content or the content text or the learning process. At the inside of this circle is what we call the curricular cycle. There's a learning need, objectives or goals are developed, the teaching and learning happens, and there's some form of assessment usually. And after that, there's usually, if it's well done, according to education best practices, a program evaluation. There's lots of other stuff that actually affects this. The teacher and the learner and what they're thinking, how they're reasoning, how they're actually doing the teaching and learning. The context, as I mentioned, that's within a system and in which there's a learning environment and a teaching environment. So all of these things are things that actually can be innovated on. Innovation can actually happen anywhere here. So that's just a brief intro. I'm going to stop sharing and I'm going to introduce John now, who is going to attempt to talk about his innovation. So go ahead. I only say attempt to talk. If your voice goes, then Ningzi will do her thing.
Okay, thank you, Dr. Snell. I'm sorry, everyone. Got something that left me the baritone voice, so I hope it'll hold for 15 minutes. So hi, everyone. Thank you for the introduction, Dr. Snell. So I'm Jonathan Houle. I'm an internist and epidemiology master's student at McGill, and I will talk to you about our project today entitled Implementation of Point-of-Care Ultrasound in University Affiliated Medical Center in Northern Ethiopia. So the only conflict of interest I have is that we signed a contract with Butterfly IQ. They provided us with devices that were slightly modified for our project, and also provided us a slight rebate on the devices in exchange for their name being mentioned in the final paper. They had no say in the design of this project, or I'd have no access to the data. So we know that point-of-care ultrasound is the standard of care in high research settings, but we have good reasons to believe that point-of-care ultrasound can also improve care in low and middle-income countries. However, they have very limited access to training. That's because in-person training is expensive and difficult to do, and because online training is very expensive. There's only a few curricula that are fully online. And there's currently, as far as we know, no focused curricula that are adapted to low-income countries per se. So we decided to develop an online focused curriculum for faculty and residents in a tertiary care center in a low-income country. To do so, we needed to start with a needs assessment. And we were clearly, earlier on, we were faced with the fact that typical educational needs assessment really focus on the learning needs and the learning objectives, and don't really take into account a lot of what's outside of the intervention itself and its impact outside of the setting of the intervention, like you may want to think of when you're doing global health delivery. So things that you might want to consider when you're doing global health is making sure that your intervention does not cause, or at least that you reduce the risk of harm as much as possible, that you're promoting autonomy, that your intervention is as sustainable as possible, that it's acceptable morally, that it's feasible, and just overall that it is setting appropriate. So what we needed to do, and we weren't exactly sure how we were going to do that, is conduct a remote, comprehensive, global health adapted needs assessment. Sorry. I just want to take a step back and tell you about the setting of our intervention. So it happens in Gondar University Hospital. That's in the city of Gondar in the Amara region, just next to the Tigray region, which you've probably heard about in the last year because of the civil war. So we've come to learn, to know about that site through two of our educational partners, Dr. Orapal Sial and Dr. Mark Clarfield, who have had a long relationship with that center and who have conducted projects over there already in the past. So it's a public university. It's also a public teaching health center. It's a center that's familiar with research methodology and medical education. They keep very good medical records. And at the time of designing this project, they had a very favorable political climate there. So now going back to the needs assessment per se, so you may know that medical education intervention, all education intervention get evaluated through their outcomes, and that these outcomes will inform the planning stage of your intervention. So when you're planning, you have to know what you're going to be assessing at the end. And likewise, the needs assessment also informs the planning stage. And what that means is that the evaluation and needs assessment are inseparable parts of an educational intervention. And that's well reflected in the curricular circle that Dr. Snell introduced in the introduction to my talk, and which is also represented in this model, which is called the SIP model by Daniel Stoffel-Beam. SIP stands for context, input, process, and product, which we won't get into the details of today, but just to know that the two first steps of this cycle, or the context evaluation and the input evaluation, are really the needs assessment and the planning stages. The following steps are the implementation and evaluation of your intervention. And what we were faced with when using this model is that it really stops at the learning objectives, at the training needs per se, and at the impact that your learning objectives have on the setting of your intervention. So let's say you're doing an intervention in the emergency room, so that's where you're going to look for an impact, not necessarily outside of the emergency room, in the community, or in society in general. So we looked for another model, and the model we found was this one. So it's the OEM model, so the organizational element model by Roger Kaufman. And it's an interesting model in that it's a top-down approach. So going from left to right here, and it divides the needs in two different parts. So in the needs proper, or also referred to as the ends, and the quasi needs, or the means. And at the far right of that model, you can see that there are the inputs. So the inputs are really the nitty-gritty details that you put into your program. So the human and material resources, your budget. It's followed by the processes, so the educational methods, the implementation strategy. And then you're moving on to your needs per se. So your training needs, which he calls the micro level of needs, which is really what your learning objectives are. And then the macro level of needs, which is the impact you're having on the setting where you're delivering your intervention. So can I do the example of the emergency room? So that's where you would be measuring your impacts in the emergency room. But what Kaufman is saying is that if you're not meeting a greater purpose than where you're doing your intervention might be completely useless. And so he added the mega level of need, which refers to as the needs outside of your intervention. So in a hospital, that might be the needs in another department. It might be the needs of the community, the needs of the country. It might also be philosophical outcomes. So key concepts that are very important to the investigators or the community where you're implementing your intervention. It also refers to the context itself, politics, and the future. So everything that is outside of your intervention. I'll give examples to get that clearer. So for instance, in a global health intervention like ours, stuff that is outside of our intervention and that is very important are avoiding harm, promoting autonomy, making sure that our intervention is sustainable, and making sure that it builds capacity. So these are just, for example, without which our intervention, even though it was successful at the learning objectives per se, might be useless if it doesn't meet these 4 points. So Kaufman's organizational element model is unique in that it does not assume usefulness based on the training program's success in attaining its learning objectives. That means that even though you're teaching your learners to use point-of-care ultrasound, even though they learn a great deal, in the end, if your intervention causes more harm than good, then your program is useless. If it promotes dependence, if it's not sustainable, and it does not increase capacity overall, then your intervention is probably not worth it. So it's a business-derived model. It was initially thought for businesses, and this usefulness is definitely true for businesses, but it's also true for medical education. But I think it's even more true in global health initiatives where resources are so scarce. So we conducted our needs assessment. We conducted 12 one-hour interviews on Zoom, plus 15-minute online surveys for each interviews. We interviewed faculty members, residents, the dean, chief of medicine, and the chief of radiology. Each interview was transcribed and coded using thematic analysis. And examples of questions that we asked to assess outcomes at the mega level were, for example, in order to assess for the risk of harm, we asked, do you think this project is really needed? And do you think there are more important needs in your department or hospital that should be addressed before this one? And do you think that the resources for this project could be taken away from other areas of the hospital where they are more needed? And then to assess for autonomy, we asked if there was any way that we could minimize investigator presence, or their thoughts on how you could do that and how we could minimize our investments. And if they thought that Gondar could afford to maintain the devices and the program without external sources of funding. And in terms of sustainability, which is of course, this overlap with autonomy, but we asked them if they were aware of any previous attempts at implementing POCUS in other departments or hospitals, and if yes, what happened? So here are issues that we identified by asking those questions specifically. So we did identify that the cost of the program could definitely divert resources from other services or priorities in the hospital. That the time put by the learners may in fact impact their learning and patient care as well, because they're very strained on time. And that was also true for faculty members who might take time away from patient care to teach POCUS, for instance. We also find that physicians may try to use POCUS to bill patients outside the hospital and work as radiologists in their private clinics. Now, in terms of autonomy, we found it was absolutely paramount that the devices be serviceable in Gondar, given that's a really big issue that they have with machines that keep breaking, have to be sent for months away at the capital at Addis Ababa, then coming back 6 months later, which makes relying on them completely useful and probably harmful. And then in terms of sustainability, we found out that the radiology department at Gondar had blocked the previous attempt at implementing POCUS in the hospital a few years ago. So what does it mean to plan at the mega level? So now we have like these key mega issues or concepts that we have, and then we want to decide what our inputs are. And I thought I would take an example to show you how thinking at the mega level impacts your choice of material resources. And one good example for that is the choice of the ultrasound machine. So this is a machine that's currently at Gondar. It's a machine, I don't know if they acquired it or if it was donated, but they were donated many machines. Might have been donated. So it's a high quality machine. It's a high resolution machine. It has advanced Doppler options for performing cardiac echo at the bedside. It's a great machine. So if I were to try to meet my training needs and my learning objectives, I could definitely do that with that machine. If I were to try to meet my department needs with my intervention or my setting needs with this machine, I would definitely meet those objectives. But what about at the mega level? What about at these key concepts that I want to include of sustainability, harm, autonomy? So not really. So it's a pretty terrible machine in that regard. So why? Because it's very expensive. So it's a machine that's worth approximately $25,000 to acquire. And even if it's donated, it costs a lot of money to maintain it. So each probe, if they need to be repaired, are worth between $2,000 and $5,000 each. The repairability is extremely low. All parts have to be ordered from the manufacturer. It needs to be repaired by an expert. It needs to be sent to the capital or even to another country. The battery life is terrible in a country where power outages happen every week and last often more than 24 hours. It's not protected for recurrent power surges, which has caused many of the previous machines to break, and it overheats during the summer. It's not Wi-Fi or Bluetooth capable, which means it's pretty terrible for data collection. And most of all, it is not sand-proof, which is a very big problem for them, as they have to roll the machine between wards outside, and the sand gets into the button, the wheels, and the little knobs. So in terms of harm, so this machine is a money pit for them. So it would most likely drain resources from other departments, or at least just money that could be used better somewhere else. In terms of autonomy, it's not good either, because they're probably going to have to rely on external funds to maintain that machine and replace it when it breaks. And in terms of sustainability, well, it's a machine that's vowed to break in the next year. So we came up with this idea. So we decided to build a POCUS station around the Butterfly IQ device. So it's a cheap probe. It's about $3,000, and it does all probes. It's an abdominal, vascular, and cardiac probe all in one. Has very good resolution, not as good as the previous machine, but quite decent. So it'd be connected to a tablet that's protected to be cleaned. So everything is protected from sand and water and disinfectant. The stand would also have a sheet for data collection with a box at the bottom to put the sheet. So for every scan, participants to our curriculum could fill a form saying why they did the scan, if it changed management, those kind of questions. And there's a UPS, so an uninterrupted power supply that's joined to that to protect against surges. There's also another battery pack at the back for additional charges. So this station costs a lot less than the previous one. It's about $4,000. It provides very good resolution, super easy to repair. All parts are orderable from Amazon. The battery life is way over 48 hours. It's doubly protected against power surges. It's Wi-Fi and Bluetooth ready. It's designed for data collection. It has a box on it. We can just put the sheet next to the screen, and it can fill it there and put it directly in there. It's very low risk of overheating, though it will need to be tested. And it is sand-proof because it is waterproof. So in terms of harm, so this is like as much as we can reduce harm in our opinion. It's very cheap machines in terms of cost for sure. In terms of autonomy, they should be able to service it directly in Gondar, except when the probe breaks, in which case it needs to be shipped, but it can be shipped by mail to Gondar. And it should definitely increase sustainability. So this is the machine itself. I'm testing at home, and it's almost ready to ship. So how can thinking at the mega level also impact the processes? So your implementation and your educational methods per se. So looking at the curriculum, so how can we do that while designing our curriculum? So avoiding harm means ensuring that the training is of great quality. As we said, time is a problem. It's time that could be taken away from patient care, so it must be time efficient. And because we were concerned about inappropriate use of POCUS, we include appropriate use of POCUS as a learning objective as part of the curriculum, so they will be evaluated on that outcome. So in terms of autonomy, the curriculum has to be free. It's fully downloadable. They'll have unlimited access to it, and they'll be basically owners of the curriculum. And there'll be minimal investigator presence. We're trying to do as much as we can online and to rely as much as we can on local experts that will train. And the sustainability of the curriculum relies on the training of the trainer session at the beginning of the curriculum, followed by refresher sessions for them. We chose to prioritize residents who already have a position at Gondar, so residents that will stay and teach afterwards. And we involve the radiologist in the process to make sure that they agree with what we're doing and teaching. This is an overview of the curriculum. So it starts at the far left with bootcamp training the trainer that is probably going to happen in Addis Ababa, in the capital, in the next month or months. That's going to be followed by enrollment of the trainees, followed by a baseline written exam, at which point we start to collect data and evaluate the curriculum. And then we give full access to the curriculum at once, followed by USKIs at 5 months, and another written exam at 6 months, another SK at 9 months, and a final written exam at 12 months, which marks the end of the data collection and curriculum evaluation, which is followed by data analysis, curriculum amendments, and start of a new cycle if it's appropriate. So our next step are to finish recording the online lectures, develop the evaluations, both the USKIs and the written examinations. There's the in-person bootcamp for training of the trainers in the capital next month or the following, and the formal launch of the curriculum. So in conclusion, we found that traditional educational models were not very well adapted to global health initiatives. However, we found that Kaufman's OEM mega level of need allowed us to put key global health concepts as the ultimate measure of success of our intervention. And therefore, by combining traditional educational models, a business-derived model, in this case, Kaufman's OEM, and global health concepts, it allowed us to develop a curriculum that we think is both pertinent and setting adapted. Thank you very much.
Thank you very much, John. If you wouldn't mind unsharing. So Jeffrey, Jeff is now going to be the muse and talk a little bit about a couple of the education concepts that underlie this, and also give us a little bit of a what's in it for you. Dr. Wiseman.
Thank you, Linda. So for the Global POCUS course design, I'm going to make 3 points. There are 3 things that stick out to me as an educator. Number one was what you did in order, the needs assessment that you created. Because in effect, Jonathan, this is a giant needs assessment, and I'm going to speak to that in a minute. Then you did something which in educational technological terms is also called an agile design, a design that changes in response to the learners. And then finally, you did a does not need assessment in the end. And you were very conscious of the power that an educator has with a learner. So first, to talk about doing a needs assessment, what educational science says is that really, in order to educate somebody, one of the most important things is to find out what they already know and where they need to go next. So knowing what your learner already knows and where they need to go is one of the most important practical steps that you can do in a clinical setting. So in a clinical setting, when you first meet a new learner, it's very helpful to have a brief orientation conversation with the learner and find out where are you, what are you already good at, and what are you working on, and how can I help you work on that? So that's what you can do in a practical clinical setting. And what Jonathan presented was a giant, much bigger process where he was doing that with the entire group of professionals that are working at this hospital in Addis Ababa. The second point is the agile design, where what agile design means is you come up with a prototype. You come up with what looks like it might work, a plan that might work, and you try it with a few representatives of the learner body to get their input on it. And you change it depending upon how well it works and how well it fits the environment that it's going to work in. And I think for us clinical educators on the wards and in the clinics and on the consult services, when you're working with a group of learners, you have no way of knowing if your education is of any use to them or not. And one of the best ways, ask your learners to give you feedback. How are we doing in terms of education? And try to find out from your learners' perspectives how well the education that you thought was going to work would work, and then change in response to their needs. So in effect, we have to be agile educators, and our favorite ways of educating don't work for everybody. And so when you find that out, be ready to change to a different way that would work. Finally, the words autonomy were all the way through Jonathan's presentation to this group of global physicians. And that to me speaks to the concepts of power in education. And the one concept that I would describe to you is Freire's use of power, where Freire says that you want to avoid a banking system. That is a system where the expert fills up the brains of the learners with expert content, and the learner is totally dependent upon the teacher for all of this wonderful learning. And what Freire says is you should not do that. You should instead have dialogue with your learners, and you learn as much from your learners as your learners learn from you. And one of the things that Jonathan learned was, guess what? There's sand everywhere in Ethiopia, and that would completely destroy a very expensive machine. So what that means to us clinical educators is that it's important to have two-way conversations with your learners and try to find out from your learners what's going on in their learning environment, and try to find out from them how you can help and how you can change the education that you would offer depending upon the learning environment and depending upon the demands that your learners are facing on the battlefield, on the clinical battlefield. So that again, Freire would say that clinical educators put themselves in a position of learning from their learners how better to support them and teach them. Thank you.
Thank you very much, Jeff. If anyone has any questions specifically about this part of the presentation, please put them in the chat now. I will also let people know that Jeff cannot go for 5 seconds without mentioning Freire, his favorite education philosopher. I don't see anything in the chat now, so I think what we'll do is we'll just go ahead with the second innovation. And so Matt, can I ask you to start talking about your innovation? And I will remind people that if they have questions, please put them in the chat. Go ahead.
So thank you everyone for having me today, Dr. Snell and Dr. Wiseman. I'm going to present my Interprofessional Crisis Resource Management course. And this was put together by a fairly large team that I'll introduce at the end, and Dr. Sun, who's really been the lead on this project. So a brief history. So crisis resource management has its origins actually in the aviation industry. In the 1970s, the National Transport and Safety Board found that human error really contributed to 70% of aviation accidents. More in-depth analysis revealed that the majority of these errors are actually related to teamwork failures rather than deficiencies in knowledge or technical skills. So this actually led to the development of a simulation-based crew resource management training program that focused on core teamwork behaviors like leadership, communication, situational awareness. And crew resource management has actually become this global standard in aviation industry since the 90s. In healthcare, anesthesiology was really the first specialty to incorporate crew resource management into their training program. But here it was adapted and referred to as crisis resource management, or CRM. Following its success in anesthesiology, CRM-based training programs soon developed in other high-risk, high-acuity specialties like ICU, neonatology, and emergency medicine. Today, these courses can be found in almost every medical specialty, as well as other healthcare disciplines. McGill, like many centers across the world, has expanded CRM training to cover multiple disciplines at the undergraduate and postgraduate level, and to be run in simulation centers across learner populations from novice to expert. And we at McGill are extremely privileged to have the renowned simulation center both at the MUHC and at the Steinberg Simulation Center. Now, historically, and due to scheduling limitations, these courses are often organized as a single discipline. For internal medicine, for example, this often consisted of code blue training and included only learners from internal medicine. Residents were often required to role play, i.e. play the role of a nurse or a respiratory therapist. And while this provided enriching learning, it wasn't always reflective of the true clinical scenarios and lacked authenticity. As many people here can attest to, code blues are notoriously hectic. They're often formed of rapid response teams that are made up of ad hoc members of various allied health professions and on-call residents. So with that in mind, we set to design a course to address this gap in training, a CRM curriculum that involved the actual stakeholders and allowed for true interprofessional simulation with the hopes of fostering collaboration. Now, this notion of interprofessional collaboration really falls in line with the Faculty of Medicine's strategic plan. The strategic plan of McGill has 3 components, one of which is to foster and encourage a culture that supports interdisciplinary and interprofessional partnership. So the primary purpose of CRM training is really to provide team-based approach to averting medical crises and mitigating errors. The key principles taught in CRM are designed to facilitate early detection of potential adverse outcomes and empower the healthcare practitioners to intervene more effectively. While each CRM course is really unique, they can overall be summarized through the following objectives listed here. So problem solving, resource utilization, situational awareness, communication, and leadership. When designing our course, it was really imperative to keep these objectives in mind and use them as a framework to develop our clinical scenarios and structure our assessment models. So here's an overview of our curriculum design. When planning a CRM curriculum, it was really essential to note that each training program has different goals for its learners. So the first step was to perform a needs assessment to identify the stakeholders and identify the most critical teamwork competencies for each learner group involved. As much as possible, we wanted to ensure that the composition of the learner population reflected the makeup of the real Code Blue teams. So that meant nursing, RT, and medicine residents. Now remember that a multidisciplinary interprofessional approach to teamwork training really provides the learners with the richest and most realistic experience possible. So because of this, our course actually took over a year to design. Once we got all the stakeholders around the table, we set out to design specific and measurable objectives for each specialty, meaning objectives for RT, objectives for nursing, and objectives for the medicine residents. Then as a team, we developed interprofessional learning objectives that applied to everyone. Now, once we established our objectives, we designed clinical cases that would actually foster a shared mental model. We also had to create novel assessment models that would be applied to all professionals in the course. Once that was complete, we then met with the simulation center experts here at the MUHC, and together with their collaboration, we've turned our dream into a reality. We created multiple CRM scenarios, each lasting around 20 minutes. And these scenarios actually utilize high fidelity mannequins that are pretty awesome. They actually simulate real life medical scenarios, and the mannequins are linked to computers to provide participants with virtual feedback and real-time clinical information. Now, this course also serendipitously allowed for research, which I'll discuss in a bit. So in regards to developing the scenarios, we wanted to ensure that the medical management was challenging, but not mysterious. We wanted participants to focus on how they can improve their CRM skills instead of debating the medical context of each case. Next, we wanted to embed trigger events throughout each scenario to provide learners with a structured opportunity to display the specific CRM behaviors we wanted to assess. So in order to be useful for our course, these scenarios needed to require interprofessional collaboration, had to present interpersonal challenges to the participants, needed to necessitate escalation and management. And that was really important because what we wanted is for people to recognize their own limitations and when to call for help or on another professional. And finally, we wanted learners to explore a differential diagnosis. The initial response really shouldn't be sufficient enough to really solve the problem. So this is a flowchart of the scenario. Each scenario required 5 participants. We had 2 nurses, a senior nurse and a junior nurse, 2 residents, a senior resident and a junior resident, and 1 respiratory therapist. Now, the course was designed in a staggered start and really in order to emulate the real-life clinical situation. So first, the nursing team would enter the room to perform a routine patient assessment. There would be a predetermined trigger event and the patient would actually start to deteriorate. The nursing team would attempt to stabilize the patient and then page the on-call doctor for help. The doctors or residents are waiting in the hallway in this case, unaware of the scenario. Once called in, they would receive verbal handover from the nurses, assess the patient, and then put into place an action plan and attempt to stabilize the patient. A second trigger event would then occur and cause further patient deterioration, and actually the patient would become unstable. The medical team is then supposed to activate a code blue, whereby the respiratory therapist would enter the scenario. Together, this interprofessional multidisciplinary team would manage and resuscitate the patient for a total of around 20 minutes. Now, immediately following the simulation, there is a debriefing. Now, structured debriefing is really a critical component of simulation-based learning. While learning does occur during the actual simulation, it's really the structured debriefing that allows for participants to review their performance and synthesize key teamwork concepts. And in order to maximize the learning potential and to foster a more collaborative discussion, we designed the cases such that there would be 2 facilitators for each clinical situation, 1 physician facilitator, and then 1 facilitator from an allied health profession, so either a nurse or an RT. And this would provide an enriching opportunity for feedback and maybe stimulate a more in-depth analysis and discussion. Now, the key here is to recognize that from design to implementation to debriefing, this entire thing has been interprofessional and required the input from varied allied health professionals. Now, crisis resource management principles are inherently subjective and they don't lend themselves well to objective examination. Nonetheless, we felt that this was an excellent opportunity and really a unique environment to perform assessments of certain behavioral characteristics we wanted to look at. So there are actually several behavioral scales that have been developed and validated in the past for CRM competencies. Some of the most well-known rating scales include the Mayo High Performance Teamwork Scale and the Ottawa Crisis Resource Management Global Rating Scale. So using those prior validated tools, we developed our own checklist that would allow for the assessment of the interprofessional objectives. Remember, these were the objectives that were designed by the interprofessional group of learners to assess key characteristics that we felt were essential for effective teamwork. So the way it worked was immediately following the scenario, participants would be handed this checklist and they would complete it as a self-evaluation on 5 critical interprofessional objectives. And we wanted it to be a self-evaluation in order to provide the individuals with the opportunity to really self-reflect on their own work. And then it can be used as a kind of guide for the debriefing with the facilitators. So this checklist really looked at 5 characteristics. 1 was the ability to demonstrate a shared mental model. 2 was to demonstrate a high standard of conduct and maintain climate of respect. 3 was to demonstrate respectful and clear communication, to recognize one's own limitations, and finally, to apply relationship building values and principles to team dynamics. Now, as I had mentioned earlier, this course really allowed for our interesting research collaboration with our partners from the MUHC. So we had the privilege to work with Jason Harley from the Sales Lab, and the Sales Lab is a simulation, affect, innovation, learning, and surgery lab. And they're examining the emotions and cognitive processes experienced by healthcare learners and professionals during team-based simulation. And it's actually really cool. So what they're doing is during our scenarios, they're audio and video recording of the entire simulation event. And if participants consent to it, they're wearing devices that will record their heart rate and their skin conductance, which is a surrogate marker for sweat. And they're looking to gain insight into the emotional activation during the simulation activity for these healthcare learners. Now, in conclusion, it's clear that simulation-based CRM training improves the cognitive and interpersonal behaviors of medical professionals. And there's actually a growing body of literature that demonstrates that effectiveness of CRM in enhancing team performances and reducing adverse outcomes in the real clinical workplace. Now, this project represents an innovation in simulation-based training for medical professionals. This is the first interprofessional crisis resource management simulation course at McGill that's actually been designed by an interprofessional group of educators with the explicit intent to foster and encourage a culture of interprofessional collaboration. Now, despite the interprofessional training being one of the 3 priorities for the Faculty of Medicine strategic plan, there were still many barriers that needed to be overcome in putting this project together. And our goal is we really need to break health professions out of these silos. And we hope that this project will serve as a success story to encourage interprofessional partnership between different professions and foster collaboration for an educational environment that really supports interdisciplinary and interprofessional teamwork. And with that in mind, I want to take this opportunity to really thank our team. So we have Dr. Hanush, who's been our medical expert content. We have Carolyn White and the entire MUHC Simulation Center. We have Jason Harley from the Sales Lab. We have Oksana Kopustina from the Ingram School of Nursing, Dr. Ningzi's son, who's been the project lead, and Chantal Pichet from Respiratory Therapy, who's been our educational specialist. So with that in mind, I'd like to thank everybody, and I look forward to hearing some questions and comments.
Thank you very much, Matt. If you can pull it down, I would ask Jeff for his education-related comments on this.
Thanks, Linda. So Matt has presented, there's so much stuff in educational stuff in Matt's presentation. I'm only going to focus on a few things. I'm going to talk about interprofessional education. I'm going to talk about your use of shared mental models and situational awareness. I'm going to talk about debriefing, and then a brief word about emotions in education. So first, interprofessional education. The theory, there are many theories that apply to interprofessional education, but the one I'll just talk about briefly here is that of authentic learning. Any learning that you do is best done in the context where it is going to be used. And so when one is running a code blue with a deteriorating patient, by nature, the kind of work that you're going to have to do will be interprofessional. There'll be a whole bunch of different professionals on that team. So this is an example of authentic learning. So what does that mean for the frontline clinician educator? What it means is that any teaching that you would offer or share with your learner has to be useful in the context that they're going to be using it. So you can, for instance, give somebody a lecture in a lecture hall on the approach to hyponatremia, and that will have a modest, small educational effect. But much better than that would be for that individual to actually work up a patient who has hyponatremia and learn how to apply that in the clinical setting to a patient with hyponatremia. When we get to situational awareness or shared mental models, this is a critical part critical theory in education that uses a cognitive approach where we try as experts to share the way we think through a problem with the learner who tries to share the way they think through a problem. And another way to summarize this is to call it making the implicit explicit, both for you as a teacher and you as a learner. So what that means, practically speaking, when you're faced with a learner in your lab or on your consult service or on the ward or in the emergency room, it really helps to ask your learner, please help me understand how you thought through this case. What were you thinking about this case? And then share what you were thinking about that case. And the differences between your thinking and your learner's thinking are very important educational points for discussion. What about debrief? That was a very important part of Matthew's innovation, and it's a critical part of any simulation that we do. And what is debrief? Debriefing. It's a fancy word for feedback. The practice of feedback has the greatest standard deviation, the greatest educational effect in learning compared to almost any other thing that we can do educationally. So all you need to do is share good feedback with your learner. You don't have to teach them anything. You don't have to do any fancy teaching technique. You don't even have to take them to a hi-fi simulation center. But if you're sharing good feedback with your learner, that will do a lot more for the learner than anything else. In the simulation center, which is an expensive place to be, 50% of the learning comes not from the simulation, but from feedback. Finally, the role of emotions in education. The theory that I would think of is something called control value theory. And what control value theory says is that the emotions that we experience when we're trying to do something or learn something are governed by how well we feel in control of our learning and how much value we place on our learning. And those emotions then feed back to our learning. So if we have major negative emotions, we can actually impair somebody's learning. But if the control and the value is very high, negative emotions can actually improve learning. So it's called control value theory. What that means for us clinician educators on the clinical battlefield is that emotions are critically important in learning. You can use the experience of a difficult event. My patient just died, and your learner is extremely emotional over it. You can use that to springboard a lot of education around how do you approach the death of a patient, how do you approach a difficult conversation, and things like that. So those would be the major theories and the major education science behind many of the things that Matthew Ades and his team have spoken about.
Thank you very much, Jeff. Again, I will encourage you to put your questions in the chat. A couple of comments I'll make. First of all, Matt's innovation actually arose from another innovation many, many years ago that Ningzi did when she was chief medical resident. Ningzi, I will accept bribes, so I don't say how many years ago that was. Chinese food would be fine, thank you. But I think it goes to show that one innovation can beget another innovation. There is a question in the chat from David Rosenblatt about if outsiders are going in, to what extent should the problem be put forward by the local country or people? I would say actually that both of these innovations relate to incorporating or going into or doing something in a different culture. Obviously, the first one in terms of a country, but the second one in terms of the different cultures of the different professions. So maybe I'll ask Jeff to address what he said a little bit more, expand on what he said in the chat about Freire. And please don't forget to put your other questions in the chat.
There was not only Dr. Rosenblatt's comment, but a comment from another observer who prefers to remain anonymous. And she mentioned, she asked if I would speak to the added layer and complexity of the cultural power dynamic of Western or developed countries doing this work in developing countries. And actually, that's a very important point. It really gets to the heart of what Freire is all about. And the key concept is avoiding what's called colonizing education. And by that, it's just a fancy way of saying we can take all of our North American ways of doing things and our North American concepts and our North American culture. And it's very easy to impose our culture on that of the people in the developing countries that we're working on. And what Ferrari says to get away from that, around that, is that when we go globally to work in another country or in another culture, we have to, as hard as our learners may be working to learn what we have to share with them, we have to work at least as hard as them, learning their culture, learning their language, and learning how they see the problem. Because sometimes how they see the problem is part of the problem. And the only way to understand that is to learn from them how they see that. And I guess it's another fancy way of saying that sometimes we think we know the answer to our problem, and we might be very wrong. And the only way to find out is to invite somebody completely different from us to take a look at that problem and get a fresh approach. And we do that all the time in medical practice. I'm sure, when you've got a difficult case, you're not sure where to go, you ask for a consult from somebody. And part of it is you need their expertise, but part of it is that you need a fresh approach from them. So that would be what I would say to that.
Thank you very much. I'm wondering if I could ask for any comments from Dr. Sun, who actually supervised both of these projects. If you'd like to add anything to the comments already made or to the challenges you came up against, anything like that.
Sure. I make maybe one comment each. For Jonathan's project, I think what has been really stood out is the determination and stamina of Jonathan, which is exemplified by the fact he almost had no voice and still was able to present outstanding presentation today. But despite all the political turmoil, the back and forth, the politics, everything that we have gone through, Jonathan pulled through this project that I don't think anyone else would have been able to do that. And I think the merging of global health with the business literature with the MedEd was really what's so unique about his project. For math project, we also went through a lot together, and I think there are a lot more political or institutional barriers that created the silos that we're working in. To break out of those silos for interprofessional education, it takes a lot of energy, more energy than we initially thought before we started this project. But again, Matt has been really determined in getting this done. And I think the things that we learn by doing this project might serve well other initiatives that's also interprofessional. So congratulations for both.
Thanks very much.
Thank you. If I can just make a comment, thank you very much to all of you. Really outstanding work and presentation, very innovative approach. I think this is really excellent and really, it's really, you can feel McGill's long-term, long-standing, I should say, educational vision in this. Dr. Fantis has a question here. Linda, I don't know if you want to take that question before we close out the rounds.
Sure. Thanks very much. We're often asked to evaluate residents on acute care, but rarely actually observe what they do. Whoops. Sorry about that. I keep getting muted. Somebody has it for me. We keep getting asked to evaluate residents on acute care, but rarely actually observe them. In simulation, is there a robust possibility for evaluation, but not there in real life? So how would you evaluate? Any tips? Maybe I'll ask John first. No, sorry, I'll ask Matt first. If you can talk about the relationship between simulation and real life, and then maybe Jeff, particularly with your hat on as education director at the Sim Center, you could talk about the relationship between learning what you learn or observing what you observe in Sim, and then its application to the authentic setting.
Well, I'd start off by saying, I'd start off by saying that, these simulation scenarios actually offer an excellent opportunity to evaluate residents. And even though it's simulation, people's autonomic system often kicks in. And even though it's a mannequin in front of you with the vital signs beeping and nurses in the room and the code blue alarm going off, people tend to react like this is a true scenario. And it offers a unique opportunity to evaluate things in a way that's really non-judgmental and allows you to sit and debrief after and discuss things more in depth than you would have the opportunity to in a clinical scenario. And for residents, we actually evaluate them aside from the interprofessional objectives. We completed their EPAs, for managing a code blue scenario. So although it's simulation, there was an opportunity to really provide effective feedback on their medical management as well. So that was distinct from the interprofessional objectives.
Jeff?
I'm just reading. I'm reading a whole bunch of other. I'm just reading Ivan Fantas's comment. Let me unmute myself. You can hear me now, I hope. So what happens if you, you're right. If you're asked to evaluate a resident's acute care skills, yet you've never actually literally been there during an acute care scenario. It's a common issue. The best, of course, is for you to be there, but that doesn't happen all the time. What you can do is use surrogates. So you can ask other people who were there, who were able to observe the resident. You can ask for your residents' recounting of what happened. But each of those sources of data have advantages and disadvantages. It's like in research, no single source of data tells the entire truth. So if you ask the resident how they did and how they felt they did, well, the resident may be biased and may want to look good in front of you and be afraid to look bad in front of you, particularly if they don't have a growth mindset. And another way might be to ask people who were also there with the resident, who might have observed the resident, but they may not want to say anything negative for fear of harming the resident's career, to give an example. Or they may want to say something negative because they have other reasons for not liking that resident. And so that would be part of the things that you'd have to think about as an evaluator. And I echo what Matthew said about the role of simulations for assessment. Yes, you can use them for assessments. The problem with simulations is that some people put on a simulated performance in the simulations. So, and that is one of the problems with simulation technology. How much of what I see of a performance in a simulated environment truly reflects what would happen in a real environment. I think the frontier of research on that is that the more emotions are provoked in a simulated environment, the more likely you are to get towards true performance. So the times, for instance, that I've tried doing a simulation myself, I really don't feel like I'm Dr. Jeffrey Wiseman trying to save this patient's life. And it's only when I get the living daylight scared out of me that the simulated patient is going to die that I flip into being myself. So there's a certain suspension of belief in a simulation when you first start getting into it. And some people, it takes a while to suspend that belief and start behaving like they are themselves. So no clear answer to an excellent question from Dr. Fantas.
Thank you very much, Jeff. I've got just one thing to say to close. We've been thinking about the process of innovations here, and we've seen two innovations that have actually arisen from a need, an interest, a spark, which led to an idea which got developed into an innovation. These are just about to be implemented, and they are being evaluated. There's a lot of things to talk about here. It shows the science behind these innovations. There's a need to look at the education evidence, use it, create new evidence, which both our innovators are in the process of doing. Both of these innovations, I think, are highly publishable. And I think both of the innovations also show the range of innovations that you can have in medical education. I'd like to thank all the speakers today for stimulating us and maybe to think a little bit about innovations, and we'd be happy to talk to you further about this. Thank you very much, Nadia, for inviting us for this.
Thank you very much to all of you for speaking today. I invite you to look at the comments, a lot of positive comments coming out. Congratulations really on all the work you've done. This was a really excellent presentation, and thank you for being here today, and thanks everyone for joining. It's 1 o'clock, so we'll close the rounds. Have a great day. Bye-bye.
Bye.